having a BMI of more than 30, she is again considered as obese. And this much of extra weight is due to the growing fetus and storing of fat to make the breast milk later, all that. But of course, it should not exceed 12 kgs. And again, not only that, it gets transmitted from generation to generation. And first and foremost, this obesity causes difficulty to conceive initially itself, and there is a greater risk of pregnancy complications and adverse birth outcomes in the subsequent pregnancy also. Not only with this, it affects the next also. And the metabolic syndrome in the offspring is transmitted from one generation to other. Like we are facing a lot of obesity nowadays. It's because of the transgenerational transmission which has occurred through many generations. So we need to fight for again so many generations to get back the thing what we had later. And again, coming to the fetal DNA, there is increased cell turnover and apoptosis of the adipocytes. So what happens? Again with the dilution, greater plasma volume of this obese mothers, which leads to lower placental fraction of this cell-free DNA in the maternal blood. So how to manage? It's very simple again. If she is obese, she should limit her diet, but this is not the time for weight reduction. She should go for a balanced, nutrient-rich diet along with exercise. That is, you change. Instead of more carbs, she can go for increased protein and more vegetables and greens, all that. Like our 88 plate model, what we say, half the plates full of greens and vegetables, and reduce the carb to just quarter plates, and increase protein equal to that of carbohydrates, so that the carbohydrate becomes a lengthy carb, and again having more of complex carbohydrates. In this way you should go, but don't try to reduce your weight. You should not do a weight reduction. Of course, in the initial trimesters we don't need extra calories, and of course 1800 calories in the early, and you need to increase further, that is in the second and third trimesters. And again, another studies by Must et al. Again has shown that this gestational weight gain is again associated with postpartum diabetes, metabolic disorders, affects the mental health, causes hypertension, dyslipidemia, cholelithiasis, coronary artery disease, osteoarthritis, sleep apnea, stroke, and certain cancers also. So again, you see this via the lipotoxic environment in the placenta. It increases the pro-inflammatory cytokines, increases oxidative stress, and causes alterations of free fatty acid transport. So what happens in the fetus? There is hypothalamic inflammation and more of lipid accumulation, alteration of the fatty acid synthesis and fatty acid oxidation, and there is high adiposity and alteration of the myogenesis, insulin signaling, adipogenesis, oxidative, all these gets transmitted to the fetus. And of course, as I said earlier, there is actually usually the obese women, they lactate the babies only for a shorter duration, and the composition, milk composition is also getting affected. There is more of lipid content, and the immunological factors are not that much like normal weight. So we can take this obesity as a prenatal problem and take it as a game changer, because as I said, it causes more problems in the mother, in the fetus, and during delivery. And not only that, it doesn't stop with that, it causes long-term effects. Again, as I said, it's getting transmitted again and again through generation to generation. So you preconceptionally you discuss the first subfertility and also obesity associated risk, and recommend some lifestyle and weight loss interventions, assess the need for treatment or treat the pre-existing condition, and refer to the specialist if necessary, and provide folic acid supplementation, and educate about the pregnancy risk, and screen for the comorbidities, and give continuously the weight loss advice, and take adequate pregnancy care. It should be a multidisciplinary care, and cardiovascular surveillance, blood pressure monitoring, gestational diabetes screening, and pregnancy weight gain and nutritional advice, and also put them on low dose aspirin. And after delivery, postpartum is equally important like preconceptional care. So maintain high suspicion for the complications, what I have mentioned already, and offer breastfeeding support early and to continue for a long time, and counsel on risk associated with obesity for women as well as the newborn, and counsel on family planning. As he said, it has effect on the subsequent pregnancy unless otherwise she becomes metabolically healthy, and recommend this lifestyle and weight loss interventions post-partum. A word about this anti-obesity drugs. This metformin are sometimes considered for overweight women, that is obese women planning pregnancy, especially those with fertility issues. And most of the anti-obesity medications what we see are contraindicated to the potential teratogenic effects or other adverse outcomes. Our GLP-1 receptor analogs, which is the hero today, is like other anti-obesity medications, are not recommended for use during pregnancy due to its potential risk, but still studies are being going on this GLP-1 receptor analog for reduction of weight in during pregnancy also. So what we need to do as an intervention strategy, first ask every problem, then assess and advise what we have said already, and make the patient agree what they have, and also keep assisting continuously to get a good outcome. Thank you.
Thank you very much, Dr. Bhavadarini ma'am, for your crystal clear presentation on prepartum, intrapartum and postpartum care on the pregnancy and obesity with the fetal complication. And at last she has made a best attempt that it will precipitate NCD disease due to insulin resistance. Thank you, ma'am.
Thank you. Thank you.
Yeah, next by Dr. I. Periyandar. Welcome you, sir.
Thank you, sir. Thank you. Respected chairperson, respected senior colleagues, my dear junior colleagues, it's my great pleasure in sharing some of my views on early GDM. The topic early GDM is a wide, and I should cover A to Z of GDM itself, except the third trimester management. And my sincere thanks to scientific committee for giving me this opportunity. And my flow of talk will go like this. Topics may be vary, but 2 minutes I will try to finish off 15 minutes. Thanks Dr. Bhavadarini for giving me 1 minute extra. And our Professor Samji P. Moses used to say, no field in medicine has highest level of controversies like that of medicine. And our Professor Dr. Seshaya used to say, no field in diabetology has highest level of controversies like that of GDM. You take into all the diagnostic criteria, treatment, everywhere there will be controversies. So I will be touching every one of them. So coming to the topic, pregnancy in the life of a woman is a well-awaited and glorious event. The event has become more sensitive nowadays because of 1 or 2 child policies of couples as well as late marriage. And a lot of infertility clinics are coming out, and to give safe outcome is our importance in the management. And for the definition, it's GDM is defined as the carbohydrate intolerance of variable severity with onset or first recognition during pregnancy. So coming to the prevalence, worldwide the incidence is 10 to 25%, and in high risk groups up to 30% of pregnancies may involve diabetes. And IDF itself repeatedly says Southeast Asia is the hub for GDM. And coming to the individual countries, UAE has highest prevalence with 36%, followed by Norway, Netherlands 27%, Japan minimum. And there is a steady increase in prevalence of hyperglycemia and pregnancy, and 1 in 7 births is affected by gestational diabetes. And in Southeast Asia, 1/4 of all births are affected by high blood glucose in pregnancy. Coming to India, so different parts of India. So Kashmir has lowest 3.8%, Lucknow more 41%, Punjab 35%, West India 9.5%, Tamilnadu 17.9%. Our professor Dr. Seshaya has his statistics. Overall prevalence of GDM was 13.9%. And coming to the classification of diabetes, so just for refreshment for the youngsters, it's classified as pre-gestational diabetes type 1, pre-gestational diabetes type 2, and secondary diabetes, and gestational diabetes truly coming IGT of pregnancy, and undiagnosed pre-existing diabetes, and true GDM. Why we should give importance to GDM is, it's a beautiful word, hyperglycemia, however trivial, is teratogenic in early pregnancy. This is what repeatedly various studies says. So this is a very popular slide, every one of us knows, first trimester, implication of first trimester hyperglycemia and second trimester hyperglycemia. And as HbA1c advances, the congenital anomaly incidences are going up, and less than 5. In this particular study, less than 5.3 normal and between 8.9 microcephaly, like that caudal regression syndrome and truncus arteriosus, like that various complications comes. And coming to there are one more importance is 2 generations are at risk of developing diabetes in the future. And diabetes complications become worse during pregnancy in all pregnant women. Though hypoglycemia is very rare, DKA can occur in type 1 diabetes patients marching through pregnancy, and retinopathy and nephropathy, that is proteinuria, may worsen during pregnancy, and retinopathy may worsen pregnancy. So these 2 complications are the real nightmare for all type 1 diabetic patients or some of the chronic type 2 diabetic patients as well. So these many studies, as I mentioned earlier, so as HbA1c increases, the complications goes up. And like this HAPO study also, I think this will be covered elaborately by Dr. Sunil Gupta, and HAPO study, as HbA1c goes up, the complication goes up. And this is one more HAPO follow-up study also, the prospective follow-up study. The risk of abnormal glucose tolerance, obesity and adiposity is high at 7 years of age in the offspring, and more evident among girls, and increased association with pre-hypertension and hypertension. Coming to the pathophysiology, so pregnancy is normally accompanied by progressive insulin resistance. The insulin resistance arises from combination of increased maternal adiposity and increased insulin desensitizing effects of hormones secreted from placenta like estrogen, progesterone, cortisol and HPL, and increased level of plasma tumor necrosis factor and low levels of adiponectin, everything which was covered by Dr. Bhavatarini in the previous lecture, they are also coming through that. So these are the other hormonal change. As pregnancy advances, the estrogen, progesterone, human placental lactogen and insulin, hyperinsulinemia, everything will increase during the normal pregnancy. So to compensate for the insulin resistance, pancreatic beta cells undergo hypertrophy, hyperplasia, and but in GDM the compensation fails and decreased insulin secretion, thereby hyperglycemia comes. This is a popular slide for UG students. We used to say this in non-pregnant adults there will be some amount of insulin secretion, some amount of insulin resistance. During pregnancy both will be more. Insulin secretion will be more, as well as insulin resistance also will be more. So insulin secretion matches insulin resistance to maintain the maternal glucose is maintained normally. But in GDM, insulin resistance will be high, but insulin secretion will be impaired. Thereby the hyperglycemia will take place. Then coming to the screening. So screening, only 2 varieties of screenings are available. One is selective and universal. In yesteryears, 1 decade back, only selective screening was available, was recommended. So that to select high risk patients like older age, high parity, pre-pregnancy weight, pregnancy weight gain, BMI, polycystic ovarian syndrome, they will be screened for GDM. Not all. But nowadays, so universal screening, all pregnant women should be screened because the incidence of is going up, and the incidence of hyperglycemia and pregnancy is very rampant in first trimester itself, early pregnancy itself. So universal screening, and that is taken by our government of Tamil Nadu also. So coming to the diagnostic criteria, so it is also a little little time and when changes. So before 1964, no diagnostic criteria. And O'Sullivan Mahan was only first to lay down guideline, and next followed by National Diabetes Diagnostic Group criteria 1979, then Carpenter-Couston criteria 1982. It's with the 2-step in USA, WHO criteria in other countries, and WHO criteria, DIPSI criteria, IA-DPSG criteria. And even in the senior gynecologist from USA also, nowadays they are practicing this, they are well versed with the 2-step procedure of Carpenter-Couston. and this is a cutoff point for the juniors. So these are the targets for the management. So fasting, all the guidelines says, including ADA, fasting should be less than 95 and 1 hour postprandial less than 140, and some authors say less than 130, and 2 hours postprandial should be less than 120, and HbA1c target of less than 6% is optimal during pregnancy if it can be achieved without significant hypoglycemia. This point should be very clear. So how to monitor? Monitoring, so usually